Good day, everyone. We are Group 5, consisting of Estrella, LICARDO, MERCADO, PARIñas, and SISON. Today, we will be discussing about a case involving a Do Not Resuscitate order on a 90-year-old female that suffered from cardiopulmonary arrest. To elaborate, a 90-year-old woman named CD was brought to the ER after experiencing cardiopulmonary arrest. The patient experienced breathing difficulty and cyanosis just before confinement. The patient was then intubated and given CPR at the ER and was successfully revived. Her medical history reveals that she has COPD and hypertension. She had then another cardiac arrest at the ER but was revived again. A neurologist gave a poor prognosis and suggested brain death based on an EEG showing minimal brain activity. As the situation was discussed among the relatives, they requested a Do Not Resuscitate order or DNR and asked to take the patient home. The ER physicians declined the request due to insufficient evaluation of the patient's condition. Thereafter, the patient was left hooked to a ventilator with IV fluids and tube feedings. In patient care, DNR orders are common in the terminal phase of the illness, which implies that the responsible physician in advance decides that in case of a cardiac arrest, neither basic nor advanced CPR should be performed. Given this, questions have arisen to accommodate the case's ethical dilemmas, which will be discussed later on. What are the principles involved in a Do Not Resuscitate order? What are the criteria for distinguishing proportionate or ordinary treatment from disproportionate or extraordinary treatment? Should there be a distinction between curing and caring? And lastly, are there cultural considerations in the signing of a DNR order? Starting with the first ethical question for the case, there are three principles noted to be involved in the DNR order. The first principle focuses on autonomy. The principle of autonomy is based on deontological reasoning, which states that moral agents have a duty to respect human dignity and treat everyone equally, regardless of the consequences of their actions. Autonomy acknowledges that people have the fundamental right to decide what happens to their bodies and to make informed decisions regarding their healthcare. In the context of a DNR order, it is the right of a patient experiencing cardiopulmonary arrest or their immediate family, if the patient is unable to make decisions, to refuse or withhold potentially life-saving interventions. This includes situations where such interventions are considered standard protocol. However, several ethical dilemmas related to DNR decisions have been considered, particularly regarding conflicts of interest between the desire to alleviate suffering and do good for the patient versus prolonging life and respecting patient autonomy. It is generally considered unethical for a physician to unilaterally suspend or discontinue a previously recorded DNR order. The principles of informed consent and patient autonomy dictate that the patient's preferences must be respected as a way of upholding the dignity of the human person. In the presented case, the doctors in charge were hesitant to discharge the patient due to inadequacy of measures taken on the disease's prognosis, thereby deciding to prolong the patient's treatment and recovery. Therefore, these doctors disregarded the patient's family's DNR order despite the family's wishes. This goes against the principle of patient autonomy and could be considered ethically harmful.
Moving on, another ethical principle involved in a Do Not Resuscitate order is non-maleficence. Generally, the principle of non-maleficence declares that all persons have a moral obligation not to harm each other. In the clinical aspect, this could be described by how in the course of achieving a beneficial outcome, doctors and other healthcare professionals have an obligation to avoid harm or to inflict the least possible harm in treating the patients. A Do Not Resuscitate order is usually applied for when the best course of action is to cease further medical interventions that cannot anymore contribute to the wellness of the patient. Hence, the guiding principle of non-maleficence, which is to avoid harm or inflict the least possible harm, is applied in a DNR. However, one conflict in the application of non-maleficence in DNRs can actually be seen in the case at hand. Herein, we can observe that the ER doctors did not agree to the request of the patient's family to apply DNR for the patient. However, from this situation, the doctors deemed that there are still further medical interventions that can possibly improve the patient's condition. This is why, even if non-maleficence is observed in a DNR order, it is still dependent on the doctor's discretion on whether a DNR is already the best option. Particularly for this scenario, choosing to agree to the DNR, which means to cease medical interventions, is actually harming the patient since there's a possibility of a higher chance of survival and a better quality of life after further treatment. Relatively, the principle of beneficence can also be applied for DNR situations. To define, in the clinical aspect, beneficence requires physicians to provide to the best of their ability all the feasible positive benefits such as to prevent harmful conditions and promote good health for patients. Beneficence involves the selection of beneficial interventions for the patient after assessment of the risk to benefit ratio. For this scenario, the ER doctors who are handling the case assessed that a DNR is not yet the best course of action. This is because, as medical practitioners, the doctors have an obligation to provide and exhaust all possible and case-appropriate interventions wherein, in the general view of things, the benefits of such interventions actually outweighs the risks. In other words, the doctors believe that there are more beneficial actions that could be done before approving a DNR order.
Let us now dive into enumeration and comparison of the criteria for distinguishing proportionate or ordinary treatment from disproportionate or extraordinary treatment. The criteria for distinguishing these treatments can vary depending on the ethical and legal frameworks of different countries or regions. However, let's talk about some general principles that are often considered. First is the assessment of medical futility, which involves the consideration whether the interventions being performed have a reasonable chance of achieving a meaningful clinical outcome. In this case, the neurologist's suggestion of brain death based on the EEG showing minimal brain activity indicates a poor prognosis. If the prognosis is such that the interventions are unlikely to result in any significant improvement or benefit for the patient, it may be considered disproportionate or extraordinary. Next is the balance between the potential benefits and burdens of the treatment. If the interventions such as the continued intubation, ventilator support, and tube feedings impose significant burdens on the patient without a reasonable likelihood of achieving meaningful improvement in their condition, it may be considered disproportionate. The burden can include physical discomfort, loss of autonomy, prolonged hospitalization, or any other negative consequences. Thirdly, the patient's prognosis, as evaluated by the neurologist, is a critical factor in determining the appropriateness of the treatment. The presence of chronic obstructive pulmonary disease or COPD, hypertension, and the poor prognosis suggested by the neurologist's assessment indicate a serious and potentially irreversible condition. If the patient's prognosis indicates a minimal chances of meaningful recovery or a terminal state, the continuous use of invasive interventions may be considered disproportionate or extraordinary. Next is the potential impact of the treatment on the patient's quality of life if the interventions being performed, such as intubation, ventilation support, do not offer a reasonable chance of restoring a satisfactory level of functioning or independence. They may be considered disproportionate. In such cases, prioritizing palliative care and focusing on maintaining comfort and dignity may be more appropriate. Lastly, the expressed wishes of the patient or any previously documented advance directives play a crucial role in decision making. In this case, the family expressed a desire to execute the Do Not Resuscitate order and bring the patient home, respecting the patient's autonomy and honoring their wishes unless there are overriding legal or ethical considerations. It is an important aspect of determining the appropriateness of the treatment.
Now, let's move on to the third ethical question. Should there be a distinction between curing and caring? To start off, cure and care are two words that are often used interchangeably. They seem to be synonyms of one another, and a lot believe that to give cure means to give care. However, this is not ultimately the case in medical and hospital settings. There are instances that curing may sacrifice the virtue of caring, and that caring may not lead to curing. It is with this that we answer the question with yes, there should be a distinction between curing and caring. And these are actually two different approaches in the practice of medicine and are better known as the cure model and the care model. In the cure model, curing is referred to as the complete restoration of health and eradication of a disease. It implies technical action that in some way prolongs the life of a patient or improves some of their physical problem. It focuses more on the quantifiable physical symptoms and responds to the cognitive need of the patient to understand their disease. On the other hand, in the care model, this is defined as the holistic process where the patient feels comforted by the treatment and relates more to the quality than to the quantity of life. It is more patient-centered and is based on the biopsychosocial model, which prioritizes collaboration between the physician and the patient and sees the patient as an individual rather than a disease carrier. To better present the distinction between caring and curing, we can use the case on our 90-year-old female patient. From the situation, it can be observed that the doctors are more prone to cure the patient, with the intent to solve the disease as they pushed her to remain hooked to the ventilator with IV fluid and tube feedings. Even though the prognosis was already defined as poor with possible brain death, the doctors prioritized cure over care and did not consider the possible pain and low quality of life that the patient will suffer during the remaining years. Meanwhile, the family in this case is more leaning towards caring for the patient. As there is already a poor prognosis and possible brain death, the family's intent to care is found within their decision to sign a Do Not Resuscitate order with the goal to bring the patient home and let their 90-year-old relative to enjoy her remaining years with less suffering and pain, thus clearly showing how they chose care over cure. To wrap up this section, we can observe that curing and caring do not equate with one another. And as future medical professionals, we can't cure every patient of every condition, may it be hypertension, diabetes, and even cancer. But that doesn't mean that we cannot care for them as a person. As stated by Trudeau's motto, cure sometimes, relieve often, but comfort always.
Finally, let's discuss the fourth ethical question. Are there cultural considerations in the signing of a DNR order? Given that each patient must have autonomy for their medical choices, what exactly is taken into account when the patient or their family signs a DNR order? Many patients and their families are influenced by their religion and cultural backgrounds when it comes to life and death. In India, for example, their culture mostly believes that their life and death is in God's hands, so it is not the individual's right to end their life through euthanasia, or more specifically, withhold life-saving procedures. Additionally, while India only legalized passive euthanasia in 2018, which includes signing a DNR, active euthanasia is not legalized. On the other hand, more westernized societies such as Australia are more likely to exercise their right for autonomy over end-of-care procedures, including signing DNR orders. Finally, other regions with specific cultural obligations such as ethical Chinese people refrain from discussing death-related concerns entirely due to Chinese traditions and culture from Taoism, Confucianism, and Buddhism. Thus, people from areas such as China and Taiwan are less likely to form advanced directives including DNR orders. Moreover, the resulting decision of the physician on what will be done could vary based on region. For instance, institutions from the USA value autonomy and individual choice, meaning they're more likely to follow a patient's orders, whereas in the UK, they are more likely to take the best interest decision as determined by the physician. Now for this case, the family signed a DNR order despite the physicians believing that there is more that could be done. In the Philippines, DNR orders are not as widely used as most Filipinos follow Catholic beliefs, which focus on the idea that life and death is in God's hands. In addition, the close family ties that Filipino families have encourage them to fight to keep their family members alive. However, as mentioned by Charm, the family chose instead to allow their elder to enjoy what is left of her life with less suffering and pain. This could also be a different perspective that many Filipinos can have in regard to having close family ties, where they believe it would be better to let their family members enjoy their remaining time, as they no longer have to watch them suffer through intubations or CPR. This also follows the religious belief of putting their life in the hands of God. Therefore, overall, cultural and religious considerations can play a big role in the signing of a DNR order, and these can vary from patient to patient. And with that, we can conclude our presentation. Thank you very much for listening, and feel free to ask us any questions.